Yeah, thank you, Asha. Thanks for inviting me here. So I'll be setting the stage for need of automation in insulin delivery. I think the previous case highlighted exactly what I'm going to talk in the next 15 or 20 minutes. So it's regarding the challenges faced by people with type 1 diabetes. So we know that insulin secretion is a very complex and a dynamic process, and it is sort of so precisely managed in the normal human uh, environment in terms of the glucose response to the insulin response to glucose in the blood, and also the insulin response to the long-term things like stimuli like insulin resistance. So it's so precisely regulated inside the bloodstream, in the bloodstream, that the ultimate goal of full normalization of glycemia seems to be distant for people with type 1 diabetes, but we are trying further and further over these years to reach a stage where we are able to reasonably manage it well. Now, what is the current state of diabetes care in people with type 1 diabetes? There's a lot of data, most of it is not very new, but this is data from the search, this is a type 1 registry to show that if you look at suboptimal A1C is about 9.5%. Even in this type 1 data from the US, almost 20% of patients have an A1C more than 9.5%. And you can see that there's a bit of difference in ethnicity, but still, overall, the control is not that great. If you look at adults with type 1 diabetes also, it's not too great. Around 20 to 30% of people have an A1C less than 7%, and 70% have an A1C which is more than 7%. And you divide it according to the age of the patients, again, you would see that it's not very great. Kids generally have a worse A1Cs, adults have better A1Cs, but overall, you can see the percentage of patients who reach an A1C less than 7% is around 20 to 30% only. Now, there's some data from India. I try to pick up data from where I could get smaller number of patients, but again, 8.5 to 9% is the overall data among patients who are on basal bolus insulin use. Now, if you look at other side of the story, like leave the hyperglycemia part, going on to hypoglycemia, this again data from the type 1 T1D exchange clinic network to show that there is an increased risk of severe hypoglycemias and diabetic ketoacidosis among patients with type 1 diabetes. And irrespective of the A1Cs, only when you reach something very close to normal, between 7 to 7.5, you have a reduction in event rates, but otherwise the event rates are higher at both sides for hypoglycemia. And as your baseline A1Cs are worse, you have an increased risk of diabetic ketoacidosis. Now, going back to the DCCT, which is possibly the most important trial in the field of type 1 diabetes, you can see that whether you are in the intensive group, that's the yellow line and the red line, whether you are in the intensively controlled group or the conventional group, you have an increased risk of hypoglycemia, severe hypoglycemias as your A1Cs comes down. At the same time, people with lesser A1Cs did have lesser risk of retinopathy, showing that people with type 1 diabetes are in a very precarious position trying to manage the high blood glucose and low blood glucose and trying to maintaining with a very narrow level of optimal blood glucose levels. So what have we done in the last so many years in terms of development of or improvements in terms of managing type 1 diabetes? There have been various improvements in terms of insulin monitoring and pumps, and I'll run through that. So first is monitoring. One is self-monitoring blood glucose and continuous glucose monitoring systems. We have moved from SMBGs now to more and more of continuous glucose monitoring. Studies have shown that, means we know that SMBG is an integral part of managing type 1 diabetes, and there's almost no way you can manage type 1 without self-monitoring of blood glucose. Again, data from registries have shown that the more number of glucose monitorings that you do, whether you are a pump user or whether you are on a basal bolus insulin, you have better A1C control. So the more the values that you generate, more decisions that you can make, and better you can reach better A1C levels. But if you really look at the sort of recommendations of SMBG in people with type 1 diabetes, you know that they have to do it ideally pre-meals, post-meals, before exercise, before bedtime. If you have hypoglycemic episodes at that point of time, between exercise, before driving, before operating hazardous machinery, etc., and etc. So SMBG is a very tedious thing to do if you're doing it in a proper way. It's a painful, tedious, and adherence. Even in very new studies, like there's a 2024 data from Saudi Arabia showing that less than 20% of patients really practice the SMBG, which we tell them to do, ideal way of looking at doing SMBG. So adherence is not very good with SMBGs. We have then moved on to continuous glucose monitoring systems, whether the intermittently scanned CGMs or the real-time CGMs. Most of us use the Abbott Freestyle Libre that in our practice, and that's an intermittently scanned CGM. And with the development of CGM, now we have more and more of real-time CGM, and that has made a difference in terms of the CGMs talking to the pumps. So over a period of time, the accuracy of CGMs have improved, and it's reached a stage of MARD, that is the mean absolute relative difference, and accuracy of CGMs. Once it's reached below 10%, now we are having things like the Freestyle Libre 2 or the Guardian sensors, which have reached very high level of accuracy that we are able to use them along with a pump, even without an SMBG supporting them. So that is a stage where we are reached now over a period of time with SMBG. And what is it continuous glucose monitoring is done in terms of reducing A1Cs and hypoglycemias? They're definitely been useful. You can see that this is the data of RCTs with intermittently scanned CGM to show that the time spent in hypoglycemia has been reduced by the use of intermittently scanned CGMs. And with real-time CGMs, you have an improvement in A1Cs to the tune of 0.4 to 0.6%, and also reduction in hypoglycemia events. So definitely, SMBG has made a difference. CGMs have made much more difference. And there are a lot of areas where CGMs are now sort of made difference in small and large studies in terms of QOLs, in terms of pregnancy outcomes, reducing the risk of decays, reducing hypoglycemias, improving TIR, etc. But most of us use the intermittently scanned CGMs for most of our patients, the ones especially not on pumps. But when you look at this data over a long period of time, over a large number of patients who are practically managed as outpatients, the amount of A1C reduction this has produced is only marginal to the tune of around 0.1, 0.2%. But definitely there's a reduction in risk of severe hypoglycemias among patients. The next developments have happened in insulin. We have moved on from 2 doses of insulin, which we used to do in the past, to basal bolus insulin, which we have been using after the DCCT. And studies have shown that more the number of pricks that you give, the better A1Cs that you achieve and the better glucose levels that you achieve. Insulins also have moved from NPH to glargine to digludec, and short-acting from analogs like regular insulin to Fiasp and Lumjev and things like that. Again, all those things have made some improvements in terms of glucose control and hypoglycemia for people with type 1 diabetes. Carbohydrate counting is again the next sort of challenge that people face. We all know that carbohydrate counting is a good practice for people with type 1 diabetes, but trying to implement it in the outpatient department is a major challenge, at least in India. And people with diabetes have to have carbohydrate counting for both meals and snacks, and also have an insulin-carb ratio to adjust their insulin dosage. And studies have shown that accurate carbohydrate counting and ICR can improve blood glucose. But the challenges remain that you have a nutritional education, which is not only the first-time education, you need to reinforce that on a periodic basis. Variable ICRs have to be calculated, or basically patients have to be really educated in terms of using these tools for calculating the meal-related insulin. And bolusing insulin is the next area which is a challenge. Again, to ideally bolus, most of our patients use a sort of fixed dosing, with very few patients using a correction bolus in our outpatient departments. So using a correction bolus is again a challenge when you are using a pump or when you're using a basal bolus insulin. And studies have shown regarding the perception of bolus dosing of insulin, most patients and physicians realize the importance of bolus dosing, and only 35% of patients were really confident with accurate bolusing of their insulin, and only 16% of physicians reported they are confident with bolus dosing of insulin. So bolus dosing, carbohydrate counting, things which look very good, but not everyone is practicing it the way it should be done. Then came the insulin pumps after a period of time, and I think this is one thing which has, in any form, has revolutionized the management of type 1 diabetes. So if you look back, it has evolved from a very large device to a biostarter, and now it is now reached a thing which you can carry it with you. And again, advancements in various aspects of the pump has occurred. Being a predominantly endocrine and diabetes audience, I think we don't need to go into too many details of this. This is one of the earliest data on basal bolus versus the pump, to show that the insulin pumps have made a significant improvement in the A1C to the tune of around 0.3%, without much of difference in terms of severe hypoglycemic episodes. So if you look at these studies, although it doesn't look very dramatic, some of these studies are based on regular insulin, some on long-acting glargine analogs, things like that. It's a mixed bag of MDIs that you can see here. Now, despite having the original sort of traditional pumps that we use, we still had challenges in terms of ongoing multiple glucose testings the patients had to do repeatedly to decide, you've seen the previous case also, to decide the bolus dosing, to decide temporary basals. You need to have a reasonable education in terms of the pumps to set the insulin pump even for an exercise, which the previous speaker had shown, leading on to hypoglycemia. Carbohydrate counting was still integral part of pump management, is still the integral part of pump management, and manual bolusing of prandial doses. And the previous pumps did not have hypoglycemia alarms also. So these are all challenges which even with pumps, earlier pumps, that people with diabetes really faced. Then came the sensor-augmented pumps, where the initial pumps had a CGM linked to a pump. That was a great achievement. Then you had low glucose suspension. That means basically when the glucose went below a target, the pump stopped itself. That is a low glucose suspension. Then we had the 640G, which actually brought in a predictive low glucose suspension, where the system predicts 20 to 30 minutes ahead where this patient is going to go into hypoglycemia and stops the pump at that point in time. So these were all small developments which has happened in the areas of pump. I think it's not good to label this as small development. These are major developments that has happened in the pump area. And did it make a difference? Yes. Once you moved from the regular pumps to the sensor-augmented pump, it did make a difference in terms of hypoglycemic episodes, with a minimum improvement in terms of A1Cs. Now, this has happened over a period of time. From a sensor-augmented pump, then it's moved on to an overnight closed loop, where overnight you don't have a meal-related glucose excursion. So you're able to have a stable closed loop at night. That is the overnight closed loop. Then it moved on to a hybrid closed loop, where your basal doses were adjusted in the closed loop system, but you still had to manually bolus. And then came the advanced hybrid closed loop system, which we're going to discuss further. Kannan will be discussing there. You had an automated correction boluses being given. So that is the major step forward in the evolution of pumps. So this is the artificial closed loop system, and the auto-correction bolus is the key to it, which I'm not going into any detail here. And this is just a data to show how the closed loop has improved over the sensor-augmented pumps in terms of reducing the glucose variability and improving the time in range. Now, this is where we have reached. We have reached from a low glucose suspend to a predictive low glucose suspend. We have reached a hybrid closed loop now. Now we are waiting for years ahead, more to come in terms of fully automated closed loop and multi-hormone closed loop pumps. So just to summarize that, I showed you the history of evolution, how each of these developments in the insulin space, in the monitoring space, in terms of pump areas where developments have happened, and people with diabetes can have a much better quality of life over a period of time, and the challenges still remain for them. Thank you.
In a delivery system, I'll be talking about certain case studies. So the first case, I myself am giving a disclaimer. This is the most unideal case for a Medtronic 780G pump. The reason why I put this as first is because it's the most simple to understand. The second and third cases are probably more ideal and it's more suited. This is a 30-year-old lady. She's a software professional from Hyderabad. She's having a BMI of around 29 and she has type 2 diabetes since the last 5 years. She has no comorbid conditions. She's planning for pregnancy soon. You can see her blood glucose parameters are not so well controlled. HbA1c is 7.8, fasting is 142, postprandial is 222. Type 2 diabetes treatment, she's on glimepiride metformin 2/500 twice daily and sitagliptin once a day. So she was counseled on insulin initiation. Now she's from a very well-to-do family. So while I consulted her on insulin initiation, I also let it slip that some people are using insulin pump during pregnancy, as was mentioned before. Then we started her on premix insulin because she's planning pregnancy, is it not? So we started on premix insulin twice a day with metformin 850 mg twice a day. She was slowly titrated to 18 before breakfast and 14 before dinner. Her fasting glucose after 15 days is 136, post meal is 189. Then, rightly said by the previous speakers, you first try to understand the pattern of what is going wrong. She was put on an AGP. So the AGP looks not very good. You can see over here that on most days, her blood glucose is varying quite widely. And this is the problem with premix insulins. You all know that 62% time in range is there on an average day. 10% is going below range, 28% is going above range. Sometimes it's post-meal hypoglycemia, sometimes it's fasting hypoglycemia. So we try to manage. We told her, okay, now let's give you better premix insulin or probably shift you to basal bolus because you're planning pregnancy. But that husband has caught on to the term. He said, insulin pump. You were talking about insulin pump. I want my wife to be on 780G pump. So I said, no. I tried to discourage that person a little bit. I tried to discourage. Not 780G pump for you. But he said, no, I want to do the best pump available for my wife. I want to give her the best possible treatment. I want 780G pump only. Fine. So 780G pump it was. So our total daily dose was 32 units per day for her in the presence of metformin. Okay, so in type 1 diabetes, we don't count metformin, we don't take into consideration. Here, this is 32 units per day. A basal rate of 50% was given, and keeping in mind her AGP, we put her on this basal rate profile. So actually in 780G pump, no, we need not be very complicated in setting basal profiles. Actually, we can just give a little bit lower in the night, a little bit higher during the day. But since we already had a AGP pattern for this lady, we decided to divide it this way. So 12 to 3, we gave 0.45 units per hour. 3 a.m. onwards, 0.55, and during the daytime, we give 0.7 units per hour. Insulin carb ratio, I personally use a 500 rule because I come from city of Hyderabad where people eat a lot of carbohydrates. So we use around 500 grams of carbs divided by the total daily dose of insulin. So she was taking around 30 units. So we made it 1 is for 15 grams of carbs. For lunch, we did it a little bit low because she had documented 2 or 3 hypoglycemias post-lunch. But predominantly the ICR was 1:15. With the active insulin time of 2 hours, and we said, why don't we try to keep the glucose between 90 to 110 in the fasting state and post-meal between 120 to 160. The basic fundamental of the insulin pump 780G is you should allow it at least 8 to 10 days to adapt. From 3rd day onwards, it starts taking on its own and starts using a little bit of artificial intelligence to understand the pattern of the patient. The things that we could do in the first few days are probably encourage the patient to enter the carbs regularly and to use the sensor all the time. And we would like to get a time and range of around greater than 70%. HbA1c should be less than 7%. And time below range, we should try to keep it below 4%. Below 54, it should be less than 1% also. So this lady has come back after 14 days. So this is the reason why I decided to present. As Dr. Subramanian said, it's not very often that you actually see that everything just falls into place as soon as you put it into a pump. This is one of the rarer cases. She's having type 2 diabetes. Within 14 days, you could see that her fasting sugars are absolutely normal. Post-breakfast, post-lunch, throughout the sugars are normal. It's only the post-dinner readings every day that are a little bit on the higher side, for which we adjusted the insulin carb ratio for the dinner alone. And this is the data that she's having right now. This is the pointer, right? So this is the data. She's having 80% of her time in range, no hypoglycemia. Her predicted HbA1c or glucose measurement index is 6.2%, and she's absolutely ready to become pregnant right now with this particular reading. Then why did I say she's unideal? Why she is not an ideal case for 780G pump is number one. Let's put it, 780G pump in type 2 diabetes is an unapproved indication. We don't use 780G pump for type 2 diabetes. It's still in the process of approval. Number two, this particular lady will probably stop using insulin, leave alone insulin pump. She's going to stop using insulin after delivery. In a 780G pump, unfortunately, once one single person uses that pump, the protocol is developed for that particular person. So after that person, we cannot sell that pump to someone else. It will either get pounded or it has to go back to US for complete reprogramming, which is a very, very difficult thing. So for type 2 diabetes, we'd rather put on a manual pump rather than an automated pump. But as I said, the husband was wanting to give the best possible treatment for his wife, and who are we to interfere at that moment? So this is case 2. Case 2 is a very, very ideal scenario where I would definitely recommend a 780G pump. She is Mrs. JN, 35 years old lady. She's having type 1 diabetes since the last 11 years. She's on basal bolus insulin. She has been admitted several times due to diabetic ketoacidosis and hypoglycemia. So you can imagine this brittle diabetes. I'm sure all of you over here would have seen brittle cases of type 1 diabetes. For the first time she developed hypoglycemia, she had seizures. And because she had seizures, she decided not to go into hypoglycemia. She used to take less boluses. She used to go frequently into diabetic ketoacidosis and get admitted also. So this is a typical brittle diabetes with HbA1c of 8 to 8.5%. Okay, this is going the other way. Yeah. So she refused insulin pump. For the initial few pumps, I kept telling her, no, insulin pump is the way to go for you. So we just try to manage her on basal bolus. And you can see that it is not only fear of hypoglycemia. She's actually having hypoglycemia in the middle of the night. And because of dawn phenomenon, her blood glucose used to always start rising after 7 o'clock, 6 to 7 in the morning. So any physician or endocrinologist who has been trying to manage her, because fasting blood sugar is not getting controlled, used to keep on increasing the basal insulin, and she used to develop more and more hypoglycemia. She was having almost 45% of time below in range, 35 to 40% time above range. So time in range is hardly anything, 15%, 20%, very, very pathetic state. Triggering factor for shifting to a pump was, in 1 month she got admitted 2 times. One was for diabetic ketoacidosis, second one was for hypoglycemia. So she said, okay, I want to take a 780G pump, it's high time. So we were a little bit careful with her now because hypoglycemia is the main concern. We gave her a very, very conservative insulin carb ratio. We told her to take 1 unit for every 30 grams of carbs that she's taking, which is very low actually. And the active insulin time, we kept it as 3 hours. Active insulin time means what? Once the bolus dose a patient gives, the automatic insulin, the correction boluses will not start for 3 hours actually. And see what happened after 14 days. After 14 days, hypoglycemia has completely disappeared from Miss JN's life. Just imagine the relief of this particular person. Okay, this particular person who's having hypoglycemia every day, hypoglycemia is gone after putting a 780G pump. Obviously, hyperglycemia is persisting. Okay, there are postprandial peaks which are going from 300 to 400 milligram per deciliter also. But hypoglycemia is gone. So step 1 we have achieved. Now we have to identify, we have to sit with her and see what is the thing. So now real-time monitoring has started now. So we looked at her sensor use. So she's extremely motivated lady. You can see that she's using the smart guard and sensor almost 96%. That means she's very, very scared and motivated as well at the same time. But her insulin carb ratio was extremely conservative. So it was part of the doctor also. I also made it very conservative because I myself was scared of her hypoglycemia. And her active insulin time was too long. So we sat and discussed with her and we finally got her to agree for 1 unit for 25 grams of carbohydrates. And active insulin time, we made it 2.5 hours. We have started reducing little bit. And now you can see that her blood glucose has improved dramatically. She has no hypoglycemia as per the bar over here. And 80% time in range. Now for a lady who was getting admitted multiple times in a corporate hospital, with so many hypoglycemias and diabetic ketoacidosis, she's having 80% time in range, no hypoglycemia. You can imagine the difference this particular pump would have made for her. I was very happy, patients were very happy. The only people who were not particularly happy were the corporate hospital where she was getting admitted again and again. So that was the problem. Oops. Next is a more challenging case, you can say. So she's a doctor herself, she's 33 years old. She came to me in her first pregnancy in 2019. She was already on an insulin pump at that time. So during pregnancy, it was very useful, easy to manage a person who was on insulin pump because she used to come regularly for monitoring. We used to adjust her basal, we used to adjust her bolus, we used to discuss so many things. But after delivery, she disappeared. So she's on the previous version of the insulin pump, Medtronic 640G. She just disappeared after that. Now, after she disappeared, it became very difficult to manage her because she was not able to adjust the basal by herself. So basal, she was not doing. Her husband was also taught and husband was also not being able to do. So even though she was using a 780G pump, her blood sugar levels were not good. HbA1c was still 7.8, fasting was 144, and postprandial was 198. This absolutely stresses the point which Dr. Ganesh and Dr. Subramanian were making. Just because you put a patient on a pump, that doesn't mean the person is going to do well forever. It's not going to happen that way. Especially in the previous versions of the pump, you need to reevaluate what is happening, what time the basal is changing, etc. She's also hypothyroid. She's using 100 microgram per day, and now she's planning for second pregnancy. So she came to us before second pregnancy. We screened her for microangiopathies, ECG, ABI, 2D echo. Everything was normal. So she was ready for the next pregnancy. TSH was also normal. So we told her, now there is 780G pump which has now come. Why don't you use that? Because it will help you manage your blood sugars very well, even when I am not around you for a long time. So after 14 days, she came. So 14 days later, you can see that for her also, hypoglycemia part was getting corrected, but her post-meal blood sugars and inter-meal blood sugars were still a little bit on the higher side. So she was having 70% time in range, but still 30% time above range, which is not yet good for a person who's trying to plan pregnancy. Her insulin carb ratio, if you've seen the calculations down, she's taking one unit for every 10 grams of carbohydrates. So how do we adjust? Now, this is a practical problem. Patient has come back to us saying, doctor, I'm already taking 780G pump, still my sugars are not getting controlled. So we'll have to take some points into consideration. Okay, the time above range is high. Now, is the blood sugar actually increasing before the meal? So you can change the timing of the bolus dose. You can make it a little bit ahead. Is the sugar increasing after the meal? Then the insulin carb ratio is not enough. So if you're taking 1 unit for every 10 carbs, maybe you can decrease it to 1 unit for every 8 grams of carbohydrates. If a lot of time below range is there, then probably the timing of the bolus needs to be checked. Or if the person is able to report the carbohydrates correctly, needs to be checked. Or the insulin carb ratio can be a little increased, maybe 1:10, like that you can make it. If the patient is not eating and still having hypoglycemia, the auto-basal target needs to be set. And also the auto-correction bolus, if it's over-correcting the patient, then we might have to change the active insulin time. Sensor use has to be encouraged. So if a person is not using sensor and expecting the sugar to go absolutely normal, it's not possible. So after 28 days, she came back, and after we changed her insulin carb ratio from 1:10 to 1:8. And just by changing it from 1:10 to 1.28, her hyperglycemia has disappeared, but hypoglycemia has started. So these are all real life cases. So this is not magic, is it not? So these are all real. Hyperglycemia went away, hypoglycemia started. Then we had to again rechange it. We made it 1:9, and after 1:9, she was pretty okay. She became pregnant. After she became pregnant, she lost to follow-up again. Then she came back again in the 28th week. Again, we checked her ABI, ECG, microangiopathy tests. All of them were normal. But you can see that the blood sugar has now started going up again. Why? When the blood sugar was so nicely controlled before pregnancy, what is happening here in the 28th week? Insulin resistance. Now, even a person who's not having diabetes, they start developing gestational diabetes in 28 weeks because of insulin resistance. So, insulin resistance is changing. Now, there is a sudden development of insulin resistance, usually 27, 28, 29. For people who manage diabetes, you see there's a sharp increase in sugar. So even the pump requires some time to recalculate. So pump is not magician, it works on artificial intelligence. It will also require some time to calculate the basal insulin levels. Bolus is something that we can do. The doctors can help, right? We cannot change the basal because basal is, the insulin sensitivity factor is calculated by the pump by an artificial intelligence algorithm. But we can collect the bolus. So what we did, she has gone back to 1:10 because during the first trimester of pregnancy, she had nausea. We titrated it over a period of 2 or 3 visits to 1:7. And just by doing the adjustments that we did, you can see now her blood glucose is now 98% in range. The time in tight range is 88%. So time in tight range is something that we look for in pregnancy. So in pregnancy, we want the blood sugar to be between 80 to 130, 140 max. And the time in tight range itself has now gone up to 80 to 85%, which is a fantastic for a person who's having type 1 diabetes and is pregnant. So I think with that, I will also just give my key takeaways. So AHCL, that is the Advanced Hybrid Closed Loop System, is a boon for type 1 diabetes patients, especially those who are having brittle diabetes. So the second case has, has driven down the picture that in brittle diabetes, AHCL will work really well. And as has been discussed, type 1 diabetes ladies who are planning pregnancy, it's good. Type 2 diabetes, I would not use it for routine management, but for somebody who has had a complete beta cell failure, beta cells have gone, a patient is going to use basal bolus insulin, then probably in addition with metformin, you can still give the AHCL also in these particular cases. But we have to remember that once the insulin pump has been put, again I'm driving your point, we cannot leave the patient alone. We have to call the patient, monitor, check the different parameters that we need to do as a doctor to get the best outcome of this particular pump as well. Especially in pregnancy, it's a dynamic state. Insulin resistance goes down in the first trimester. It goes up during the third trimester. We'll have to monitor them much more frequently at that time. So with that, I'll rest my case now.
It is yours.
Thank you very much, and I thank the organizers, Dr. Nihal sir, as well for giving me this opportunity. And a thank to ISPE as well for taking me as part of their faculty in their ISPE Ideal group. A lot of my knowledge and my understanding of the pumps have grown tremendously for being part of that from being part of that group. So I think we've seen this transition of pumps, simultaneously transition of type 1 diabetes care, in fact preventing type 1 diabetes with immunosuppression. So there is a lot of things happening that has helped management of type 1 diabetes. As I mentioned before, the thing that has really changed diabetes management has been sensors. Sensor is for people who look like who see photo album and who see video. There's a little difference, right? You see photo albums, one frame of photograph, and you flip the page, a next frame of photograph. When you see a video that is continuous from the one frame to the other. So that's the difference between an SMBG and a CGM. So when you have CGMs, we are moving away from just only HbA1c to the words that you will keep on hearing: time in range, target range, time above range, time below range, and glucose management index. So this, I think, has really revolutionized management of T1DM. Now, this very nice paper showed that if you are on insulin pump and you wear a sensor, the sensor is not talking to the pump. This is called the sensor augmented insulin pump therapy. Patient is having a sensor, patient is having a pump, but the sensor will tell you if you're having hypoglycemias, it will alert you if you're having hyperglycemias. It showed that just by merely wearing a sensor, you got your HbA1c down, both for children and adults. And more importantly, what Dr. Mathew John mentioned, the more you use the sensor, the better the HbA1c control. So what really brought the HbA1c under control was effective use of sensor. And obviously, hypoglycemia also came down with the sensor augmented insulin pump therapy. Then came the threshold-based insulin pump interruption. So as soon as you had hypoglycemia, the pump would interrupt, and so the pump would stop giving insulin, and your sugars started going below 60, and then it will resume after 2 hours once your sugars have crossed the lower limit, or sometimes you can manually start it as well. And that again showed that your glycated HbA1cs were not very different. So there was a concern that every time you stop the pump for hypoglycemia, does your HbA1c go up? Does your DKA chance go up? No, it did not happen that way. And in fact, when you look at the suspend group, the threshold of the number of episodes of hypoglycemias, particularly nocturnal and combined, were significantly lower. Next technology that we discussed was the predictive low glucose suspend. Why allow the glucose to become low and then stop the pump? Why not stop the pump before it actually becomes low? So here the pump suspends the smart guard. The word smart guard here suspends the insulin when the sensor glucose is going to approach a preset low limit, probably by about 20 to 30 minutes. And therefore, you will have your glucose start coming up. And once it is starting to go up, then it will resume the basal insulin. This suspend before low or predictive low glucose suspend again became a very, very important a technological advancement, helping the insulin pumps and helping patients avoid nocturnal hypoglycemias. In fact, when a meta-analysis was done using this particular technology of predictive low glucose suspend, the difference between a PLGS compared to a sensor augmented pump was that you spent 17 minutes of less hypoglycemia compared to 26.3 minutes of hypoglycemia with the sensor augmented pump. So these may look small numbers, but they're very important, particularly for the comfort of the patient as well as for the family when you're looking at hypoglycemia risk at night. We move on to the next important advancement, the automated insulin delivery. So certain terms have been, kind of spoken again and again. So I just wanted to clarify those terms. Closed loop system. When you say a closed loop system, the glucose monitor, there is a sensor and the pump talk to each other via the computer algorithm. It used to be called artificial pancreas, but the term is discouraged now because pancreas has got exocrine function. We're not really mimicking the exocrine function. We're not using glucagon or anything like that. So the word artificial pancreas is not really used. Closed loop means you have two things talking to each other based on an algorithm. Hybrid closed loop system where it is a partially automated, where you also, but it requires the user to input the carbohydrate intake. So in other words, you'll have to tell the pump when you're actually going to eat and how much you're going to eat. A fully closed loop system, not yet fully available, but where you don't have to tell anything to the pump, and pump will take care of things including food intake, exercise and etc. But that's still in development, not yet available. The closed loop mode. So when in the closed loop mode, the system is working automatically. There is no manual input required. Meal announcement, exercise announcement. Of course, we spoke about time and range. So in the automated insulin delivery, you have the continuous glucose monitor measuring the interstitial fluid glucose, very important. Algorithm determines the insulin dose. Insulin pump will adjust the delivery. So you can see here, the sugar is going up via the sensor data. As soon as the pump gets the data, it pushes more pumps out small micro boluses of insulin. These are all rapid acting insulin, and once the sugars start coming down because of the predictive low glucose, it will suspend your pump, and then as it starts going up, so it starts restarting again. So what was initially you could have seen the older pump where they have said units per hour. They give the insulin as an infusion. Here, the insulin, the basal, is given as a micro boluses. Every 5 minutes, there is a micro bolus based on your prediction of where your sugars are. A lot of algorithms for this. I will leave the most complex part to Dr. Ganesh because that's going to be the toughest part, how the machine really operates this way. But there are 3 different algorithms, the PID, the MPC, and the fuzzy logic. What is the advanced hybrid closed loop system? So this is an example of that. So when you can see that there are green bars here. The green bars are your basal insulin micro boluses. But you notice that despite going to a particular maximum, the sugars are continuously rising. So the pump notices that, okay, I have given my micro boluses at a steady state and I have reached a maximum set point, but the sugar is still going up. So what does it do? It starts deploying the correction boluses. So once it does the correction bolus a few times, then the sugars start coming down. Then the pump does not require any correction bolus. Again here, because it has started coming down here, there's an automatic suspension, and then let's allow. So it avoids the glucose from becoming too high. It avoids the glucose from becoming too low. So the word basal bolus therapy is now kind of changed in a 780G as whether it is a user-initiated bolus or is it an automated insulin bolus? So whether your user is going to initiate by telling the pump that I'm going to have some carbs, or the pump itself is going to keep giving boluses to maintain the sugar at a tight level, whether it is going to be just the usual micro boluses or whether it's going to be a correction bolus as well. The other thing that has changed is we will now be treating to a target, not to a range, but to a target number, whether it can be 100, whether it can be 110, or it can be 120. And that's how a usual, the 780G pump highlights this advanced hybrid closed loop system. Now, we should know that there are other pumps that are available across the world, and maybe pretty soon we may also be having them, but it is important for us to understand the various systems that are available in the market. So this is the Minimed, which initially was the 670, 770G, but then I think the 780G has become the most popular, the most advanced form of the algorithm available, and most importantly, it's compatible with the Apple Watch. So I think it's become quite popular, and also uses the Guardian 4 sensor, which again does not require calibration and has the meal detection algorithm. So that makes it very quite popular. The Diaby Loop, the Cam Diab, here the app or the algorithm is on an app, not on the pump. Here the algorithm of the 780G is on the pump, whereas the algorithms of these ones are on an app. And because of that, the CAM diap can actually be used interoperable between multiple pumps. The Omnipod has the algorithm in each pod, so each pod has a separate algorithm for itself. The targets that you can set with each of these pumps, the targets for the Minimed usually between 100, 110, 120. You can use 150 if you are using a temporary target. For the CAM diab, you have quite a large, wide range of targets that you can actually use from 80 to 200, whereas the control, the tandem model, as well as the Diaby loop, you have fairly fixed targets of 112 to 160, and then the Omnipod gives you an advantage of having an increments of 10, so 110 to 120 up to 150. And if you look at correction boluses, the Minimed 780G allows you correction boluses which is purely algorithm based. So even if you want to correct the sugar, if you are very anxious, the sugars are still high, you cannot really correct it because the pump is deciding. And that is one of the reasons why a lot of patients, if they want to give a correction bolus, but they don't, pump is not giving it, they'll give what is called a fake carbs. They'll fake the pump saying that I'm going to eat 10 grams or 20 grams of carbs and make the pump give that extra correction bolus. So here Minimed gives only a correction which is algorithm based, whereas the tandem and the Omnipod has both automated and manual correction. So the most important point is, what can the doctor actually change on these automated pumps? They're all automated. What can I do? In the 780G, there are only 3 things that you can change. You can change the insulin carb ratio, which Dr. Santosh mentioned in his presentation, the active insulin time, this is usually set between 2 to 4 hours, and the target glucose, which is usually between 100, 110, or 120. Whereas the other pumps have a much more wider areas of change that you can actually do. The latest islet bionic pancreas, or the beta bionics, requires you to enter only the body weight. Rest of everything is calculated by the pump itself. And you would have to just announce to the pump, what kind of meal am I eating? Am I eating a regular meal, more than regular meal, or less than regular meal? Not even the carbs. So that's where we are. I think we need more data to know if that really works well in the long-term setting. Again, the age of approval, I think with the Omnipod and the CAM diab have age group of 1 to 2. Most of the other pumps have been approved for 6 or 7 years and above. And keep in mind, 780G pump is not approved for pregnancies because you really cannot set a target below 100, but in pregnancy, the targets of fasting sugars are much lower than that. People are tech savvy. They don't want to go with one company. They want to put many products of various companies and make them talk to each other using a software loop that they can do. Yes, that is called the do-it-yourself pump. You need to be really tech savvy to combine different forms of sensor with the different pump and use algorithms behind. But again, be careful. This has to be done under supervision. And if something goes wrong, nobody will take responsibility if the pump fails. What is in the pipeline? We have the Tide Pool loop. We know Tide Pool as an organization helping us with the glucometer readings. They submitted their regulation for the FDA. And you have the InReader, which is the dual hormone bihormonal insulin pump. Now, does this really help? And I think this is a very starking response to see how when you put them on a closed loop system, on a hybrid closed loop system, you can see how the graph actually narrows down from the previous, the gray one shows before putting them on the pump and after putting them on the pump, both for children and this is for the adult group of population, that the coefficient of variation and the standard deviations come down pretty well. And this is not just with one study, there's now meta-analysis showing that 2 hours and 27 minutes you get favorable response with a closed loop compared to other forms of pump therapy, and HbA1c drops by 0.3. You may all wonder why HbA1c only 0.3, sir, what big deal about that? But keep in mind, every time you avoid hypoglycemia, the HbA1c may not show a drop, and that is why the HbA1c difference may not be very important. What is more important is that your time in range is good, your time below range also becomes significantly different when you're using the advanced closed loop system. And interestingly, the greatest improvement in glycemic control is seen in those who have the lowest baseline time in range or the highest HbA1c. So sometimes it is our prejudice to feel that people who cannot do this, people who cannot do that, you're not fit for a pump, you don't have any discipline. Sometimes those are the patients in whom proper education and a timely counseling can actually help, and they can do quite well on the newer technology systems. Now, is this all only restricted to the experimental studies? Is this all only restricted to company-sponsored studies? No. In fact, even in real-world studies, you can show that the time in range improved with closed-loop technology to 27.6%, A1C dropped by 1.7%. In fact, even diabetes distress score came down as well. Quality of life is a very important metric when you go on to these expensive technologies, and it has not been studied in detail. There are some benefits, obviously. There is decreased diabetes distress, but there is not much of difference in treatment satisfaction in some of the earlier studies. Some studies have shown that this being life-changing, sense of normality return to paid jobs, better sleep to both the person with diabetes and the family. And also, some people have complained about the burdens of wearing a device, a requirement of discipline, skin reactions, data alarm fatigue, sleep quality, and etc. So the important thing is they should not think this as a miracle. It's not a miracle. You've got to work for it. And if you're on a 780G, you take up the responsibility of handling it properly. So what is the recommendations from the ISPAD? It is a strongly recommended Class A recommendation for school-age children, 7 to 14, adolescent and adults, all on type 1 diabetes. It's a Class B recommendation for preschool children and older adults, and Class C for those with moderate to severe hypoglycemia and those with comorbidities with T1DM, including CKD and gastroparesis. It's still not fully recommended for the other forms of diabetes, T2DM, cystic fibrosis-related diabetes, pancreatic diabetes, and hospital inpatient setting of diabetes. I think we need more data, so there's still not strong recommendations for these. The pumps available, we still have the 720G, which is the manual mode. Keep in mind, 720 and 780G don't look very different. They are the same pumps. In fact, 780 is exactly functioning as what a 720 will do. The only thing different, it has got the smart gut technology or the advanced hybrid closed loop. So if you are going out of the hybrid closed loop, you should know how a normal pump works. So a lot of times when patients are starting on a pump, it may be sensible to run them through the manual mode well, make them understand the manual mode well before they move to the smart guard technology. So I'm just putting up the cost of these things involved. You have the sensors that you'll have to change. You have to change a quick set. So you have to keep in mind, this is not just a one-time affair. I found a donor to give me money for the pump. No, but every month you'll have to shell out at least 15 to 25,000. So you'll have to keep in mind that these things are expensive and you'll have to pay for that. So before you start somebody on an AID system, if they are on MDI and SMBG, I prefer to always move them to a CGM first. Understand CGM better, make them sure they know the CGM properly. If they are on MDI and CGM, then I definitely put them on the pump, few weeks, manual mode, and then switch them to the AID. If they are on pump and the SMBG, then I strongly recommend that they go to the pump with the CGM before even thinking about AID, because their old pump may just be very good. You just don't know. And understanding their patterns may all that make a big difference. If they're already on pump and CGM and they want to change over, that may be probably the easiest transition that we can usually make. And if they're already on one system, you have to understand that in India, currently we have only one AID system which is officially marketable. Again, before setting up the 780G, it's important to know the basic stuff, self-management skills, blood glucose checking, ketone checking, administration of insulin through other techniques. In case your pump fails, you need to have a backup plan, review of the default basal delivery systems, correction doses in case of system malfunction, identifying diabetes emergencies, and also to remind how to identify infusion set failure. Setting up the 780G pump will require you to put in a basal rate. You'll have to set up a basal rate for the first 48 hours, and then the pump will take over. The insulin carb ratio, usually 500 divided by the total daily dose. Sometimes if you want to be a little aggressive, 350 divided by the total daily dose. Target glucose only 100, 110 or 120. The active insulin time is between 2 to 4 hours, and you can sometimes do temporary targets at 150 also. Real world data show that if you set the target as 100 and your AIT as 2, that's when you get the best possible outcomes with these pumps. When you put them on a pump, what are the important things? Consistently wear the CGM. It's very important to wear the CGM. If you don't wear the CGM, you're not going to be activating the smart guard, and you will not be really on the AID system. Be patient with it. It will not work immediately. It will take some time to understand you and help you. Trust it. A lot of times the point is about trust. Now, whether it will work for me or not, sometimes they try to override it, they try to gamify it, that will not really work. Pre-meal bolusing is so important, an important diabetes discipline point that you'll have to give your bolus before the meals. You can't expect that I'll start eating and then give my bolus, your sugars will go up high. Less aggressive hypoglycemia. I think I mentioned this point that you don't have to be very aggressive with your hypoglycemia correction. Not consider the alerts as a nuisance, and then not try to trick the pump many times. And in special situations like when you are sick, when you're on steroids, 780G, the automatic mode may not help you. You may have to go back to the manual mode so that you can hike up your doses or your basal rates to a much higher level. Exercise is very important. I think it's important to set up a temporary basal or an exercise mode 1 to 2 hours prior to the exercise. If you are having the typical learning that we teach patients is to have a snack before you exercise. If you have a snack before exercise when you're on a 780G, the pump will give you more insulin, and you may actually have hypoglycemia during the exercise. So it's not a good idea to have a snack before the exercise. In fact, you reduce the basal rate 1 to 2 hours prior to the exercise. Avoid the snack if your glucose is above 120. Reduce your pre-meal bolus if you're within 3 hours of window of exercising. You can take an unannounced 10 to 20 grams carbs if your sugars are going low, so that you will not have hypoglycemia during the exercise. You may have to reduce your basal rate up to 6 hours if required, and post-exercise meal bolus can also be reduced if required as well. So some important strategies that you can help the patients as well. The last part of my talk is on what does a download actually look like. So when the patient comes to you for a follow-up, they will bring you these graphs, a lot of data to look at. You can't do it in one clinic visit. I always ask them to send me a copy so that I can sit patiently and read it and then talk to them or call them back. First thing you want to look at is how effectively they use the smart guard. More than 85% is very important for you to interpret the data further. So smart guard use, manual mode use, sensor wear. These are 3 important settings you have to first look at. Second, you want to look at your time and range, these beautiful bar charts that will give you where they are. Number 3, you look at the glycemic indices, you look at the GMI, coefficient of variations, and their average blood glucose. Number 4, you look at their insulin metrics. What is their basal dose? What is their bolus? How much of it is autocorrection? How much of it is basal? Generally, basal dose being a little less, about 40% or so, is a good idea to have them good control. And then you have your graphs where you can actually see the insulin carb ratio below, and you can see their curves day to day and go over this with the patient on what happened on specific days. And I think Santosh and other people have given explanations on these things. The last part, which I think is very important to mention, is to look at the meal page. Look at how the insulin carb ratio. So this is the 1 hour before the meal bolus and 4 hours after the meal bolus. Breakfast, lunch, dinner, and overnight. And there are 2 different patients. And you can see that the breakfast bolus is nicely given well before the breakfast, whereas if you see the lunch and the dinner, the bolus is taken just before the meal, so the sugars are already gone up high, and it's starting to become a little difficult for them to control. And here you see the patient is giving overnight boluses quite a bit. He's almost giving around 19 boluses in the overnight, and he's putting about 25 grams overnight, which he's trying to probably fake the system to get the glucose under control. So this important graph will also tell you what to change, the ICR, in pre-meal bolusing, or to also importantly think, considering the carbohydrate intake that the patient is having as well. Now you all looked at the Medtronic. You also have something called Dexcom. Dexcom clarity is a little bit more easier to view, easy on the eyes because the numbers are a little less. You can see that it gives you a nice picture about the CGM data, the time in range. The first page and the last page is almost similar. It gives you various glycemic glucose metrics as well as the time in range graphs. It also tells you, by analyzing 3 days of data, it will give you recommendations that the sugars are high between 3 to 5 p.m. and this is what they consider doing. So it also gives you interpretation of the data as well when you look at the Dexcom parameters, and also gives you the best day. This particular day was the best glucose. So maybe you can talk to your patient and see what they did good on that day and replicate some of the practices that they have done that day. It also gives you a comparison between two 14-day window to see where things have become better. Obviously, you can see how sugars have gotten better over time with some proper education and mealtime insulin dosing. There's something called the CARES paradigm, where you look at calculate, adjust, revert, educate, and sensor. So these are all parameters that you will check through with each visit so that you can adjust their insulin pump better. It's not only about the pump, not only about the software, not only about the hardware, it's about the healthcare providers, follower function. Who's following up the pump? Is the patient or the relatives? The customer support, as well as the training and support systems. So this is now an ecosystem. You want to have a good ecosystem around you that can help you manage these patients, and that's very, very important in management of these patients. Thank you very much.
So in this particular talk, this is a highly theoretical talk, which talks about what is the mechanism and how is this automation being made possible. This is the outline of my talk. We've seen Dr. Mathew John has explained scientifically why there is a need for automation of insulin delivery, which is not difficult to imagine considering the amount of tasks that a person or family with type 1 diabetes is involved with. Other than their other life situations, they are supposed to remember to take insulin, they are supposed to take it before meals, they are supposed to count carbs, correct for high sugars, manage low sugars, manage different situations. And it is obvious that for any single, and invariably in most families, there is only one care provider. It is not that a team of people is managing the particular child. So it becomes too much to handle, and therefore some degree of automation does give relief to these people. We've seen what is a closed loop insulin pump. Basically, we have one arm where we are getting information from a continuous glucose monitoring sensor. And we have another arm where insulin delivery is being administered continuously in the subcutaneous tissue. Both of them are happening in the subcutaneous tissue, which has its own fallacies. I mean, ideally one would want to have maybe a portal delivery of insulin or something like that, but subcutaneous delivery of insulin as well as subcutaneous glucose distribution has its own challenges, which we must remember. Now, the algorithm acts as a bridge between the two. What is the meaning of control algorithm? A control algorithm is basically a program which is processing the information that is being derived from the sensor and processing that information to tell the insulin delivery system about how much insulin to deliver. So the control algorithm is processing glucose information and translating it into advice of insulin. This largely happens through microboluses. So every 5 minutes the information arrives and the information is processed, and if necessary, microboluses of insulin are being delivered. Closed loop technology has evolved over a period of time. It is not an overnight invention. Many of you would have seen this picture of Dr. Arnold Kadish with a very bulky insulin pump, which has intravenous insulin therapy and glucagon therapy and intravenous glucose assessment. Then subsequently, there was this biostator device, which was largely used for research purposes because it was not possible to use this for a clinical purpose. And even this device processed information from the glucose data to with the help of this formula to calculate the insulin infusion rate. One of the earliest wearable device was launched by actually in Japan in 1980s. by Dr. Shichiri and team, which had this wearable kind of device along with the insulin infusion set, insulin infusion catheter, and a glucose sensor which was inserted in the subcutaneous place. In 2009, JDRF gave a roadmap for the insulin therapy, insulin pump therapy to evolve. And we've had previous pumps which had insulin delivery being shut off at hypoglycemia or before hypoglycemia. And now we have reached this stage where the basal insulin therapy is automated. Why we call hybrid? Because basal insulin therapy is automated and the meal boluses are being manually administered by the user. That's why it is hybrid. The day when we are able to do both these things automatically, that will be a fully automated insulin closed loop. We may very soon reach that stage in near future. And ideally, one would like to have a fully automated multi-hormone, which means insulin glucagon in the pump. Now, these control algorithms can be of various types. These are the ones which are currently used algorithms. One of the one that is available in India, Medtronic 780G, uses a PID algorithm. Although like 670G only had this PID algorithm, 780G has some additional modules which I will explain to you. Then there is a model predictive control, MPC, which most of the other companies use. Omnipod, Tandem T-Slim Control IQ, and CAM apps, these use MPC algorithm. And there is something called as fuzzy logic. So let us try and understand. Now we have to, like, I have had to keep my medical hat and kind of think like an engineer or some IT kind of a person in understanding these algorithms. So PID is one of the very widely used algorithm. For example, we are sitting in this air-conditioned room and the air condition sets the temperature at a certain, the temperature is set at a certain degree Celsius. And the way it is maintained is one of the mechanism is PID controller. So how does PID operate? So what does PID means? Proportional, integral, and derivative. There are three components to this. Now let us say that I am driving a car, which is a self-driven car, and that car is supposed to be driven along a central line. It has to be driven along a central line. Now, if my position is too far to the right or too far to the left of the center, and I kind of correct that to get into the central line, that is a proportional component. So how far I am away from my target. So in terms of glucose, if my glucose target is 100 and my blood glucose is 200, how far I am away from the target? That is a proportional component. Now let us say this car is being driven. I think that it is being driven in a straight line, but often it happens that slowly you are drifting to the right side or to the left side. So over a period of time, ultimately after maybe half an hour of driving in this kind of fashion, you will be ending to right or to left. So these slow errors that are there, that is called as integral component. So how long you have been deviating from the target value. The third is derivative component, where like I was driving and then suddenly some buffalo or something came and I suddenly took my steering to right. So there was a rapid change in terms of the direction. So how fast is the blood glucose changing? So how far away from the target, how long this abnormality has been going on, and how fast, what is the rate of change. So PID takes into consideration all these to adjust your blood glucose values. So there's a proportional component, integral component, and derivative component. Typically, if we are calculating correction doses manually, what we will see is only the blood glucose value. We don't have, unless we are using CGM, we don't have information about what is happening over a period of time. So in this, there are multiple inputs. Is PID a little bit clear? You will have to read it few more times to understand it a little better. Then coming to MPC, as the name suggests, it is a model which is predicting something. So this model is using the information of the glucose values and the insulin doses that are being administered at this particular time. Let us say I have this information of insulin infusion being administered and the glucose values. This information is used to predict what is going to happen at periodic time intervals. Let us say k plus 2, k plus 3, k plus 4, so on and so forth. Okay, so this model is predicting what is going to be the glucose at maybe 5 minutes down the line, 10 minutes down the line. And based on that, it is going to suggest that this is going to be the glucose, so let the insulin infusion rate be this. So let us take an example. So in this diagram, this is the current time, and this is the glucose value, and this is the glucose insulin infusion rate. Now, the pump suggests a first sequence of proposed insulin infusion. So this is based on this much information. Based on this suggested sequence of proposed insulin infusion, it also suggests a sequence of estimated blood glucose values. Now, the pump has seen that if I am giving this infusion, because time is moving, so this information is being processed every few minutes. So now I see that with this infusion, the glucose values are going to drift away from my reference trajectory. So the pump now suggests a second sequence of proposed insulin infusion. And then it keeps on doing this till the glucose values are being brought to the reference trajectory. Okay? So in these pumps, there is a personal or individualized basal insulin profile that is set. If the pump predicts that the glucose values are going to be okay, then the insulin infusion happens along the set profile. If the glucose values are going to be high in the future, the pump automatically increases the insulin infusion rate. If they are predicted to be low in the future, then the insulin infusion values are going to be less, reduced. So this is a model predictive control. Then the third is fuzzy logic. Now for computer, the computer logic is binary. So for example, if we have to say, if we define that less than 40 degrees Celsius water is more than 40 degrees Celsius water is hot, then the computer will say less than 40, 39.8 is cold. But human logic is not like that. If more than 40 is hot, 35 is maybe warm, lukewarm, 25 is okay, less than 10 is cold. So there are degrees of human logic. So what fuzzy logic does is basically it is taking the expertise of a care provider and characteristics of that particular individual to devise if and then rules. For example, my blood glucose is 200 and I am going to exercise. Okay, so there is this and rule. So 150 and exercising. The insulin pump will not then give a correction bolus. Okay, am I clear? So basically, there could be situations like exercise, there could be situations like stress, meals. So these kind of logics are added to the system. As of now, we don't have, any pump which is commercially available pump using this, but there are pumps under development which are going to be helpful because the previous two algorithms are good because we are adjusting the basal insulin only. The moment we are going to think of meal and exercise and other things, we are going to have need better algorithms. Let us focus a little bit more on 780G because that is the one which we are using. So 780G, what it is doing is every midnight while we are sleeping, 780G is working to calculate from the previous data that what is going to be the sensitivity factor, what is going to be the total basal rates, and the PID gains, etc. So every midnight these parameters are set. There is a basal controller, which is basically a PID algorithm, and there are some other modules which I will elaborate in the subsequent. So there is a correction dose module and there is a meal detection module. These are additional features of 780G over the 670G insulin pump. And then we've already seen that there are some parameters which cannot be modified. For example, in the smart or in the auto mode, the insulin sensitivity factor cannot be decided by the user. It will be decided by the algorithm itself. It is important to understand that even if you are using 780G, the manual mode settings are important because the sensor may fail, or the sensor may be dysfunctional, or there might be situation like sickness, etc. So even while you are on a 780G pump, the manual settings are also important. So there's a manual mode and there is an auto mode. All this we are talking about is a auto mode. Manual mode is something which I hope that you've been educated about previously, what we used to use in the 640G and the previous models of the insulin pump, basically. Let us talk a little bit about auto correction in 780G. Now, the blood glucose is being managed by basal insulin delivery. Let us say that the glucose is being exceeded for some reason, either because there was some meal or there was some problem because of which the blood glucose is high. Now, the auto correction bolus will happen if maximum auto-basal delivery is reached. We cannot decide maximum auto-basal delivery. The algorithm decides maximum auto-basal delivery. So if the pump decides that maximum basal has been given, but still the blood glucose values are more than 120, then the pump will give auto correction bolus. Okay, auto correction bolus. Now the correction target is set at 120. For auto correction boluses, pump is going to correct till the blood glucose value of 120 is what it is aiming for. Uses the sensor glucose readings, and this can be delivered every 5 minutes. So every 5 minutes it's going to deliver correction bolus, which is calculated using the same formula that you use basically. The actual observed glucose minus target glucose divided by insulin sensitivity factor. The only difference is here ISF is calculated by the algorithm. Okay? And it would subtract any insulin on board if you have set that active insulin time. So it will subtract insulin on board. So there's something called a safe correction module. Now, the chance is that if you are over bolusing, if you're giving too many correction boluses, you may end up getting a hypoglycemia. So what is the safety with respect to that? So what it does is based on the initial glucose values, the pump calculates X amount of bolus. But there is a prediction that original correction bolus, if the pump feels that in the next 2 hours it is going to cause a hypoglycemia, it is going to reach the threshold of 50 milligram per deciliter, then the pump is going to automatically by itself reduce the amount of bolus that was initially decided. So then it will administer a 50% or 25% reduction. It will administer a reduction which makes sure that at the end of 2 hours, the blood glucose remains more than 80 milligrams per deciliter in this module. Now, if the pump detects a meal, now you will say that how if the user doesn't announce carbs, how does a pump detect a meal? It detects a meal by but the pump has the previous history of meal announcement, and if there is a rapid increase of blood glucose value, so the slope of increase, the magnitude of increase, and the duration of sensor glucose values, based on that the pump is concluding that this guy is eating without telling me. Okay? So when meal detection module chips in, this threshold that was set at 80, now if you are kind of compensating for a so-called missed meal bolus, you don't want this unnecessary threshold, right? Like if you have this threshold, then you will end up giving less insulin. So the pump, if the meal detection module is active, the pump reduces this threshold. Okay? And the safe meal bolus, again with the same mechanism, ensures that you give meal bolus only enough not to cause a glucose value of hypoglycemia by the end of 4 hours of the bolus. So there is a safe correction bolus and there is a safe meal bolus module. This is in addition to the PID controller that we discussed a while ago. Just to explain with the help of a CGM, tracing. This is tracing of one of my very cooperative and very good child with type 1 diabetes. You can see that the blood glucose values here are, this green line is your target that is set. This can be 100, this can be 110, this can be 120. Optimal setting is you set it at 100. You can have a temporary target set of 150 during exercise. If you have set a temporary target, the pump will not give autocorrection boluses. The autocorrection boluses are automatically switched off if you have set the target of 150 milligram per deciliter. So this is our line. This is where we are supposed to come again and again. So what pump is doing is that now, because the blood glucose values here, sensor glucose values are high, it is constantly administering these small purple blocks that you see here. These are all the correction boluses. This is also because you can see that the maximum basal insulin, this pink area that you see, that is a basal insulin. So maximum basal has reached. Despite of that, the glucose values are high. Therefore, pump is continuously administering correction boluses. And as an effect of that, the glucose values are now coming down. The moment it sees that there is a rapid slope, see now actually the glucose values have not come to 100 here. But if you see below, the basal insulin therapy is kind of stopped here. Because there is some active insulin from the correction boluses, and the pump is seeing that the glucose is declining rapidly. So therefore the pump has reduced the basal insulin. But when it sees again it is now flat, the basal insulin has resumed. Here, this is a user-initiated bolus. So the user has entered carbohydrate, the pump has suggested, the bolus wizard has suggested a bolus, and the bolus has been administered by the user. But as you can see here, that probably the bolus has been administered after the meal has begun. Okay? So typically this should not be done irrespective of what sort of therapy you are on. The insulin bolus has to be taken always before the meal. In case of regular insulin, at least 30 to 40 minutes before the meal. In case of short-acting analogs like Lispro, Aspart, Glulysin, at least 15 minutes before meals. And in case of faster-acting, ultra-rapid-acting analogs, 5 to 10 minutes, 5 minutes before meal. Fiasp and Lumjev. So again, the blood glucose values are high. It is giving correction boluses. Okay, so this diagram kind of explains how and you get a summary of what is the bolus being administered and what is the autocorrection being administered. And this summary is also there in the initial summary page that Dr. Kannan showed. And ideally, if the person is taking, if the carbohydrate counting is good, if the person is taking meals before, insulin dose before the meals, and the meals are relatively healthy, the amount of correction boluses required will be less. So if the person is having good control and requiring less correction boluses, that means they are doing a good job about their lifestyle. To see some last couple of slides on some data, now there are plenty of studies now to show that hybrid closed loop pump therapy improves glycemic outcomes with respect to time in range, reduction of hypoglycemia, reduction of severe ketoacidosis, etc., as compared to conventional basal bolus therapy. But this is one such large population-based study which compared closed loop and open loop therapy. So I'm not going into articles of closed loop versus conventional basal bolus. That's a clear advantage there. But now we are comparing closed loop versus open loop. So this is a DPV registry, the European registry data of about 14,000 people with type 1 diabetes. Half of them on closed loop and half of them on open loop, which showed reduction of hypoglycemic coma and diabetic ketoacidosis was much lesser in closed loop therapy compared to open loop therapy. And in terms of the HbA1c values, the HbA1c values were something like 7.34 as against 7.5% in open loop therapy. Also, the time that is spent in range was about 64% as against 52% in open loop therapy. So this large population-based data clearly shows advantages of closed loop therapy over the previous open loop pump therapy. Now, which algorithm is better? I tried to search literature, so there were a couple of studies. So this was this 2016. Remember that this is a 2016 study. This is an old study, which kind of compared MPC and PID in a 27.5-hour supervised closed loop pump sessions. And they were challenged with overnight, they saw what was the overnight control after a 65-gram carb dinner, then 50-gram breakfast, and an unannounced 65-gram lunch. So there about 30 patients, 15, it was a crossover study, so all of them had both the therapies in 1 week and then other therapy in the next week. And the primary endpoint was TIR between 70 to 180. Secondary endpoint was about hypoglycemia, hyperglycemia, need of outside intervention. This was the inclusion, this was the process that was followed. And they found that the mean TIR was greater for MPC than PID, about 74 versus 64%. And low overall and post unannounced meal glucose values in MPC. Probably, firstly, this study had just 30 sample size, and also it is a 2016 study. So a lot of things have happened, and therefore these additional modules of the PID in the 780G. So there is no data currently comparing these modules along with the MPC pump. Again, this meta-analysis kind of published in 2022 in Diabetes Metabolic Syndrome Journal of 41 studies, but again heavily kind of influenced by the studies with MPC, because there are 5 or 6 companies with MPC. And PID as of now is only used in one company's algorithm. This study also kind of tried to say MPC basal algorithm was associated with higher time in range. I think the final word is not out yet. I think we need better and more studies. As of now, it seems to me that both PID-based devices and MPC-based devices do give us significantly better control as compared to the conventional therapy or with the open loop pump therapy. Now, what's in the future? The future is quite exciting because in addition to the current algorithms, we may have wearable wristbands which kind of pick up changes in your heart rate, changes in your sweating, changes in your pulse rate. I have additional modules such as to determine exercise, meals, stress, sleep, and use all these inputs to modify the insulin therapy. This is called as multivariate artificial pancreas. So in addition to the blood glucose values, you are using all other inputs to modify the insulin pump therapy. So clearly the future is very exciting with respect to automation. Automation can improve outcomes and caregiver burden. Improved control achieved without increase in the hypoglycemia. Current algorithms are adjusting basal insulin and partially correcting for the missed meal doses. Don't go home with a message that 780G, so then there is no need of taking meal bolus. No, not like that. No amount of these small corrections can compensate for a proper meal bolus that is taken. Okay, it is a protective mechanism. Yes, it is better than missing boluses altogether, but missing boluses is not recommended if you're using 780G for your meals. Fully automated insulin delivery may soon become a reality, and it would be very exciting that this is going to happen in our lifetime. Thank you.